we're having a panel this weekend on why Medicare for All must be national. However, given the talk you just did, I do want to also ask, what are some of the most common things you hear about Canada's system that you want to debunk when it comes to let's push state by state?
Me?
Yes.
Oh, well, Canada's system unfolded province by province, but I have to say that during this pandemic, I have wished so many times that we had a national health service. We had 13 contact tracing apps being developed, one in every province. There's been lots of times when we've wished that we had a national health service, but we don't. In that sense, it was a provincially implemented system to begin with, but it's a very different story, I think, for the United States because you already have Medicare. You should just drop the age limit to like 0, like birth.
Yeah, absolutely. And after this, we do have I have an exclusive interview with Larry Sanders, Bernard's brother, who was the healthcare spokesperson for the Green Party in UK, and also a UK gentleman who's a streamer, to explain some issues with the NHS as well. So it's kind of like, is that the ultimate ideal? Yeah, I mean, yeah, for a lot of people, but I think it's so important for people to realize, like, we cannot stop. It's always going to be improvement of whatever we're given at this point. Andy, Dr. Coates, would you like to give your presentation now? And I just want to remind everyone to put comments if you want to ask anything, and then the other Andy will be reading them when he puts them up on the stream.
Yeah, I'd be delighted to speak, and I hope Claudia Fegan joins us, who's a treasured colleague and a great leader. This is very hard because talking to the screen is just very hard. I practice in an acute care hospital, a very big acute care hospital, where the privilege of the position is that there's no one in our society who really escapes the hospital. We all face crucial illness, acute illness, hospitalizable illness. We all die. And when I was soon out of training, I realized that most patients who die in a hospital, and that perhaps I should be comfortable with that process if I were to practice medicine in a hospital. And that led to a board certification in hospice and palliative medicine, but it really was motivated by the social reality that people die in hospitals. And I have now attended many, many deaths. With a little bit of social conscience, you can see that there are hideous inequalities, ridiculous injustices, and so many preventable tragedies. With the consciousness of the health policy on the level of Dr. Malinow or Dr. Woolhandler, and a little bit of the consciousness of the history as given by Ted Brown, it becomes a very vivid, everyday struggle. So on my service, I will have a patient with managed Medicare, maybe United, maybe Humana, maybe WellPoint, doesn't matter. The managed Medicare will deny the patient acute rehab after their trauma, after their hip fracture, because they are protecting their margin. They want to have a profit, and acute rehab is a lot more expensive than subacute rehab, which takes place in a nursing home. There was a time when I was practicing in Troy, and there were patients who had a particular managed Medicare, and there were no rehab options whatsoever because it was a new product and they hadn't made agreements with any facilities. And so therefore the patients that had just signed up with them for their managed Medicare couldn't get to rehab. There are much more shocking injustices in our system. I would think that medical deportations, in other words, someone without documents, an undocumented person who's severely injured or perhaps needs dialysis in the United States, will be sometimes sent home by their hospital in a extra legal deportation to their home country where medical care may or may not be available. The American Medical Association Ethics Committee took this up and reminded physicians that we have an obligation to a safe discharge plan. In other words, it would not be ethical to discharge a patient to another country where death is certain. So the shocking injustices are there. It's not just a scrum about whether or not patients get a little bit better or a little bit worse benefits. The systemic racism is appalling, and I've borne witness many times in many ways, and I have tried my best to change my local institution, to change my community, to change consciousness of my colleagues, but the fact is we are pressing against 400 years of history, and we do not yet have the power to reverse things lickety split. And so therefore, the witness bearing gets to be incredibly painful. And I'd be glad to talk about that. With respect to what we heard tonight, tonight we heard a lot about the health care delivery system, if you can, the medical delivery system, the medicine and surgery that we all need, and how it gets provided and how it gets paid for. And that's a beginning. But I like to say that although I practice internal medicine, the fact is we all know that health and illness springs from external medicine. The real conditions around us, the social conditions we live in, our resources, our exposures, we're all living downstream these days. And with that consciousness, it should lead to an interest and an understanding in public health. And that's why I believe that this call tonight, if you're listening, I have a very hard time imagining who you are because of the screen, but I would want you to know that this is an essential step for this planet. It will take an incredible mass movement of millions of people to get a little bit of healthcare justice in the United States of America. But if that can happen, it will change the world. It is so important. What we understand is that we all will need help. We will all get sick. We will all die. We will all need the hospital. At some point, we all need the help. And the point about healthcare is that it's not altruism for someone to give you that help. It's basic human solidarity. We, as doctors and nurses and aides at the bedside and pharmacists and social workers and name your allied caregiver, we do this because we know that we will someday be in that bed, that we too would like to be as healthy as we possibly can, that we will need this help. This is a fact of modern life, and it needs to be recognized as a right. It's a very, very important struggle. And it touches on the question of the legitimacy of the people that rule the society. The people that rule our society are under all kinds of threats about their own legitimacy. Sometimes I think it's comical. For example, the neo-fascists rail against the legitimacy of the government as they scream for the power of the government. There's this incredible contradiction, this incredible hypocrisy. Well, of course, the legitimacy that they want is the legitimacy for no one. The libertarian idea that you can go into the woods and come back with your F-150 sucked out of your thumb. No one made it for you. It just appeared. It's an incredibly stupid ideology. It should be laughed at. It's not laughed at. It's actually the official ideology. that we all need to be our own selves, our own country. It's silly. The point about healthcare is that this is the future legitimacy of the leadership of society. Health is essential to freedom. Health is essential to life. Health is essential to education. Everyone deserves their best chance at health, and we mean everyone. This is about justice. This is about equity. Health is fundamental, and we must have health. That's a very big question. That's beyond medical delivery systems. That's beyond going to the doctor. That's beyond the emergency room. That has to do with how society is organized so that people are not made sick by their exposures, so that we have reasonable working conditions and working environments, where we live, our water supply. The big question of external medicine is the question of health. And the government, the people that would lead the future of this society, planet Earth, the people that will lead us forward, will gain their legitimacy from emphasizing health and the science that gets us to health. And in that context, with respect to Professor Brown's beautiful presentation, we have seen an incredible onslaught of right-wing activism for 100 years against planning. Never mind socialism, call it planning. We want to have some healthcare planning. We want everyone to have the chance at the best possible healthcare. This is why we invite you, all of you activists, to study the nuts and bolts of this healthcare policy. Because if you understand the policy, you understand how ridiculous it is that we don't have what we should deserve: a dignified health system that's ready for us when we're sick and also wants us to be as healthy as possible at all times. Some of what health policy science teaches us is that user fees, meaning cash when you have to see a doctor or need help, or copays or coinsurance, any kind of cash out of your pocket, discourages people from getting necessary care. This is proven many ways in health policy. It is very bad health policy because science tells us that this discourages people from living longer. So we should do away with all user fees. Middlemen, I sometimes joke that there's no problem in the hospital that more middlemen can't fix. Middlemen are not the answer. We do not need more consultants. We need fewer consultants. We need people to get out of the way of the nurse and the physician at the bedside and stop trying to, quote unquote, gatekeep in the interest of managing the resources. We need caregivers and their patients to make the decisions. And then, most corrosive of all, we cannot have profiteering in medicine. The idea that when someone is sick, it is a time for someone else to make a profit is unethical. It's appalling. It is no way to organize a system. And in fact, when it does organize the system, it cheats the patient out of essential resources. I could say much more. I think I'll stop there. I'm very grateful for this opportunity to participate, and I look forward to hearing Dr. Fegan.
Thank you so much. And you bring up an excellent point about environmental racism. And that is one of the biggest issues of why we need national improved Medicare for all, because it does not matter if you are a citizen or what have you. And we're going to start seeing a lot of, climate refugees and what have you. What is in your practice, do you have a particular story that sticks out to you as someone who could not get the care that they needed and had to leave the US?
So fortunately, in my practice, I have had near encounters with medical deportation, and I'm in a position to suggest maybe that's not what we want to do for this patient. But it has certainly been a fact. One of the things that's interesting about New York is that there are patients who do not have documents who are able to get hemodialysis, which is important, right? So that's a big incremental difference. But what should happen if you went home to your home country? Would you be able to continue your hemodialysis? These are very dramatic, real life, modern problems. In terms of the institutional racism, I have had unbelievably painful experiences where, with my patients' families, I have simply listened and understood that they have been treated in the most undignified, unbelievable way. I don't know if any one story wins more than another, but it's a fact of life in this system that if you're poor and not used to sticking up for yourself in a certain way, you might just wait your turn, and that might turn out to be deadly.
Absolutely. I am going to try to bring Dr. Fagan in. Andy, can we try? Can you hear us, Dr. Fagan? Claudia, can you hear us? Make sure to see if your mute button is on. Okay, unfortunately, it seems like she cannot hear us.
I can hear you.
So what I want to do at this point, I'm sorry.
I can hear you.
Oh, yay, awesome. Do you want to, we'll just have to not, virtually see you, but we definitely want to hear from you. So can you tell us what you wanted to share with us tonight?
It's utterly frustrating because I missed Andy and Karen's remarks. So I'm not sure what's been said. I enjoyed the previous presentation, but I just wanted to remind folks that the United States is the only industrialized country that doesn't guarantee access to healthcare for everyone who lives here. And we spend more per person on healthcare than anyone else in the world. But it's American arrogance that we believe we have the best healthcare in the world and we can't learn from anyone else. That American exceptionalism. We don't excel in any public health measure compared to any other industrialized country, whether it's life expectancy, infant mortality. I think about maternal mortality, which has quadrupled in the time in which I've been in practice in the U.S. And it's not just embarrassing, it's negligent. And you look at, as a nation, we've never accepted responsibility for the health of our country, as evidenced by our response to COVID-19, where people living in the United States, one of the wealthiest countries in the world, had the greatest risk of death from COVID, that we couldn't figure out why we had greater mortality and morbidity among people of color, because those are the people who have least access to healthcare in the United States. That we spend so much money on excluding people from healthcare. The first thing you see when you go into a healthcare facility in the United States, whether it's a clinic, a hospital, or emergency department, it's the registration desk. And the role of the registration desk is to determine how will the care be paid for that you're going to receive. And that's the first thing, your first encounter. If you're attending this conference, most people already believe that we already spend enough on healthcare in the United States. We just allow too many people who are not engaged in the delivery of healthcare to take profit from it. And so if we were going to fix it, what should it look like? If we were going to fix healthcare, because I can't really say that we have a healthcare system but what should it look like? And for so many people, they say, okay, well, fee for service, which used to be quite common in the United States. They say, well, that was the wrong way, because when you pay people for the care that they deliver, that it provides too much of an incentive to deliver too much care. And then we swung the other way and said, well, managed care, that we have capitation, and that we should give health people who are engaged in healthcare delivery a set amount of funds and say, you should deliver the care that's most appropriate. And the incentive there is to deliver too little care, because whatever you don't spend on healthcare, you get to keep in profit. And as a result of that, the United States has never really effectively addressed the question about how do we provide the most care with the funds we have for everyone? When do we accept responsibility for everyone who lives here? And where is it that we have to decide, oh, you're a citizen, and so you're entitled to something more, as opposed to, no, you immigrated here. You know, the late Quentin Young used to say that the problem with the indigenous folks in the United States, the Native Americans, was that they had a poor immigration policy. That we were taken over by folks from other parts of the world who decided they were more entitled to the riches of the country than the people who were here first. And so I take great pride in the fact that I get to be the chief medical officer for a healthcare system in Cook County, which Chicago was part of, where we're able to take care of everyone regardless of their ability to pay. And we don't ask people to prove where they're from or, you know, who they belong to before we decide what care we can deliver. Unfortunately, that is not the model that we have gone with in the United States. It's embarrassing that a country that has so much in terms of resources decides to be so limiting in providing access to care. And we, instead of trying to think about what would improve the health of our population, we have an attitude of, I've got mine, you get yours, and too bad if you're not one of those folks fortunate enough to have access. We, as Andy talked about, the structural racism that exists in the United States today, we act shocked that not providing people the very basics of healthcare. And when I talk about healthcare, I'm not just talking about the medical delivery of medication, but recognizing that healthcare includes safe housing, uh, includes safe food to consume, includes clean air and clean water. It includes having green spaces in which you can exercise and meditate and appreciate the environment around you. We have a very self-absorbed approach to healthcare in the United States. And it means those who have can have, and those who do not have are the have-nots. And oh, well, that's unfortunate, but not our problem. So I don't understand the technical reasons why my camera, which was working all fine all evening, is not working. But I wanted to say that we can do better, that every other country in the world, even poor countries, do better than we do, because at least they acknowledge that they have some responsibility for the people who live within their borders. And I'll stop there.
You bring up some really great points.